Welcome, everybody. We're excited to have you for the next 45 minutes for this webinar focused on in-house CCM programs. We have a lot to cover, so I want to kind of get right into it with some introductions as well as a brief overview of CCM, and then we'll open it up to why we're all here, a Q&A for our panelists. So my name is Austin Bruni. I'll be your moderator today. I am an account executive here at Family. And just for some quick background, so Family is sponsoring this. This is a webinar focused on successful in-house CCM programs. At the end of this, we will provide some contact information and a general overview if you want to stay and kind of hear what Family has to offer. But we are, in one sentence, a vendor solution that is equipping organizations to implement successful in-house CCM programs. That's a product of both proven workflows and patient engagement technology. So at the end of this, we'll provide some more information if you'd like to learn how Family may be able to help you all. The real reason we're here, though, is for these two. So we're excited to have both Heather and Dr. Scott here to help take us through their experience thus far with in-house CCM. So I'd like to introduce both of them, give you a background, and then just ask both panelists to just say hi to the crowd. Heather, I'll start with you. So Heather's the practice manager of Arthritis Center of Lexington, a 7-provider rheumatology group in Lexington, Kentucky, beautiful city. Heather implemented CCM for ACL in May of 2020, right in the middle of the COVID pandemic. And her team has been providing this service to patients for over a year now. In that time frame, they have quickly grown their in-house program to roughly 900 patients enrolled and have sustained that size ever since. We're excited to hear today what that experience has been like in the specialist setting, what it has meant for your patients, and what it has meant for the practice. Heather, excited to have you.
Thanks for having me. Great.
Dr. Scott. So Dr. Shane Scott is the physician owner of Internal Medicine and Pediatrics Clinic of New Albany, Mississippi, 10-provider primary care group. Now, the practice has been providing CCM services for, I believe, roughly 4 years. After 3 years of using the EMR to manage this program, recently switched to partnering with Family just last October. In this time frame, their in-house program has grown from 300 patients to 845 total enrolled, and from 150 patients per care manager to now roughly 400. Excited today to hear about how CCM has affected your practice the past 4 years, what it has meant for you as the physician and the owner, and what the impact has been from your tremendous growth. Dr. Scott, we're excited to have you as well.
Thank you.
Excellent. So the format of today is going to primarily be Q&A. I will lead it as the moderator, asking questions about the program and picking both of these panelists' brains on CCM. But we do want to open this up to the audience. The best mechanism for that will be using this chat that a few of you are already using to submit questions throughout this conversation. I will pause roughly 3 times throughout this Q&A to help field some questions from the audience and ask those. Obviously, don't be shy. It's a great opportunity to learn from two who have been doing it for quite some time. Now, before we begin, Nabil, I will ask you to do a poll. We feel like it would be important to do a quick refresher of CCM just in 30 seconds. But if you don't mind doing this quick poll just to see where our audience stands on familiarity with CCM.
And I'll ask folks who may have voted in the previous iteration of the poll, please vote again. We unfortunately had to clear the previous results.
Give that 30 seconds. Great. So while those funnel in, like I said, for those that answered not familiar, wanted to quickly give you this 30 second for context as we delve into the Q&A here. So CCM program that came out in 2015, stands for chronic care management. And this program is incentivizing proactive preventive care to specific populations. When you look at patient eligibility, you're looking at your Medicare Advantage, in some states, Medicaid. And in the case of Heather Goodwill at ACL, some of your commercial payers, like Blue Cross Blue Shield, are reimbursing for this. Now, again, the patients we want to approach for this, that Medicare wants you to approach for this, are patients with 2 or more chronic conditions. And what you'll hear a lot from today is how majority of this is handled not by Dr. Scott, but by Dr. Scott's staff, not by Heather Goodwill or her providers, but by care managers. And that's what makes this program unique is clinical staff time counts for it. And it is a time-based code of about 20 minutes of non-face-to-face care monthly. There's a slew of activities that groups are already doing that count towards that 20 minutes. We won't go through all the codes here. There's quite a bit you can reimburse for, but that is a general overview of CCM. So with that, let's get to why we're all here and begin the Q&A. So Dr. Scott, I will begin with you. I think a good first question to start off with is, what made you decide to implement CCM for your practice roughly 4 years ago? And how does CCM fit into your vision for the practice moving forward?
So CCM basically was a mechanism that we can use to take better care of our patients. So we are internal medicine and pediatric based, probably 50% each. And so when Medicare gave us this resource, it allowed us to spend more time with patients and get reimbursed for it. So all those phone calls that my personal MA nurse was fielding as far as, did he really tell me to stop that medication, or was I supposed to double that? I don't remember. All that has been shifted to the CCM team. And so it's allowed my nurse to focus more on in the moment, in the clinic, getting those patients in the rooms and fielding their questions rather than doing a lot of follow-up. So it's allowed us to increase the care of our patients, give them personalized attention. They know who the people are that are calling. They have seen their faces in the clinic. They have, they can talk about the ball game that happened last night in the community. So all those things help them identify that, hey, they actually are concerned with who I am, and they know they have a direct relationship with me. So if there's a problem, then I'm just a couple doors down. They can come ask me a question. So basically, it's kind of like concierge for Medicare population. It is probably the best way to think about it.
Excellent, appreciate it. And to tap onto that or tag onto that, how do you explain to patients or the program to patients? I mean, I guess in 2 to 3 sentences, a patient comes into the office, they hear about this program, you're sitting down with them during their visit. How do you explain it to this Medicare population?
Often I explain it as an answer to the need that they have. So the quickest and the easiest way to do that is if I'm adjusting a blood pressure medication or looking at glucose numbers, I'll say, there's a great way. I need to know about your numbers as these adjustments in the next 5 to 7 days. I'm going to introduce you to my chronic care nurse. Her name is Mary Ray, and she's going to come in here and get you signed up for the program. You'll be able to text her with those numbers, and she's going to relay those to me. So it works out best if it's an answer to the problem or a need that they have. And there's almost 100% uptake when it's presented in that fashion.
Excellent. Yeah, I don't know. I do want to hit on this idea of your program right now is roughly 900. And we looked at what is that enrollment rate versus your entire population. I believe that's 65% of your Medicare population is enrolled in your CCM program, which is just phenomenal. Obviously, there's a huge demand from your patients, and we can kind of dig into that a little bit later. But appreciate that. Heather, changing you, similar question. As a patient-centered specialist group, how does CCM kind of fit into your care model, and how does it fit into where you want to take ACL in the next few years?
We had an obligation to provide additional services to our patient through our PCSP certification. And we realized that the traditional see and treat framework just wasn't giving the patients the touch time that they needed. Our physicians are very busy and they feel compelled because of their panels to turn over those visits rapidly, and they were not able to do it in a way they felt honored the patient. And so CCM just came in and works in collaboration with the office visit to where a patient feels like we have hands on them all the way through until their next appointment. And it's worked really well for our patients because they've had a single touch. One contact every week checking on them, and they know if they text her, she's going to respond. And in our population, they're predominantly elderly, and we thought there's no way this is going to work for them. It's just not the demographic that's suitable, and they love it. They don't have to fight the phone tree, and they don't have to feel anxious about saying the wrong thing. They can be thoughtful in their messages, and it works really well.
Great. And just to expand on that, because you and I have talked quite a bit in terms of as a rheumatology practice and arthritis, there's obviously specific conditions you're focusing on. There's specific quality metrics that you're looking to track. Do you mind just providing more insight into kind of the quality outcomes you're looking to improve through CCM?
Sure. We want patients to have lower disease activity. So we want to know that they're taking their medicine. So when they come into the office, they're able to truly know if that medication is working or not before we switch them. We're wanting to know that they have a quality of life. So are their daily living activities possible or are they not? And a lot of times you don't know that unless you ask the question. And in an exam type situation, our physicians are going over labs and they're going over radiology, and they weren't able to just dig in the way that we were with CCM.
Got it. Excellent. So regarding program impact, Dr. Scott, I'll bring it back to you. So what difference has this made for the patients enrolled? Perhaps you have patient stories to highlight, or a patient coming in explaining what this has meant to have contact with Mary Ray, to have Mary Ray checking in on her. Do you want to provide any color as to kind of the difference you're hearing this make for your patients?
Yeah. So, especially during COVID, when contact was not encouraged, our CCM program, because we had family, was still up and running. And so so that was a huge, even we had an ice storm here in March, I believe February, March, where the office closed for a week. Mary Ray was still able to work from home, contact all of our CCM patients, check in on them. Do you need anything? Are your pipes frozen? So those type things really helped her mesh with the with our patients and make them feel that it wasn't just a transactional type of thing, but it was more relational. And, she sends out these questions weekly, twice weekly, and she'll often get back, hey, thank you for checking in on me. I really feel valued. And so it's very encouraging for her to know that she's making an impact, even though she's caring for hundreds of patients, that she may not be able to looking at them, but she's making impact just through a text message.
Yeah, that's great to hear too. I was just talking to a client yesterday who said our care manager gets patients all the time. They don't want to see Dr. Scott now. They want to go see the CM manager because that's who they're talking to. One of them brought their dog. But no, that's exciting to hear, and excited to hear the impact it's been for Mary Ray. What has it meant for you as the provider? Again, has this added a lot of work to your plate? How has it helped funnel more data and patient care to you as a provider? If you just don't mind walking through what it's meant for you.
Yeah, so it's allowed me to delegate some tasks to a specific group of people that I can hold accountable. So when I'll send advanced messages to Mary Ray through our electronic medical record to say, call and check on Ms. Smith for her blood pressure change next week. There's a result that we need to be following up on. So it's actually allowed me to focus more on patient care that it's in my office and allow her to kind of look at labs and things like that. And we've also empowered her to make some changes as people call in with blood pressure readings, glucose readings, then she's empowered to make some changes through protocols that we have set out. Anything varies from that protocol, then obviously she lets us know. So that's been very helpful, so that I don't have to have my finger necessarily on every call that comes in. So it's really freed me to do what I need to do during clinic hours, and then she alerts me when things need some extra attention.
Excellent. Yeah, Heather, I think you're the one who kind of brought up to us this idea of saving clicks in the EMR, right? Something your providers talk about, where these patients have this point of contact to handle low priority, non-urgent matter that typically would have funneled all the way to your providers, which they had to get to at the end of the day. Spend 6 to 7 clicks per encounter. Now that's being handled by the care manager. I don't know, do you want to add any color to that as well, from what you've heard from your providers?
I can give an immediate example. A lot of our patients that are immune compromised had a lot of questions about the COVID vaccine, as an example. And our care manager had parameters that she could answer those questions. And traditionally, the call would come in to the front desk. The front desk would type up the message in the EMR. They didn't have the skills. They would send it to the doc. The doc, in between their day or at night, would review the message, send a response, send it to their medical assistant. The medical assistant then calls the patient doesn't answer, and we're going back and forth all day. But now they'll text our care manager, Crystal, she'll respond, and it's done.
Saves all that, huh?
Mm-hmm.
Yeah, that's great. Thank you for that from both of you. In terms of the workload for you, Dr. Scott, and for you, Heather, and your entire team there. 2 more questions before we take a pause and take some of these questions. We got a bunch coming in here, which is exciting. Dr. Scott, I was asking you about the impact for you as the provider. As the owner of the practice, what has the impact been? We're digging a lot into the clinical impact, but financially, do you mind providing any color as to what this CCM at scale has done for you, for your practice financially?
Yeah, it's been very positive. Before we instituted family to help us with our CCM program, we were probably billing out 130 on a good month for our CCM charges. Now, we're billing 500 to 600 out a month. Yeah. So it's been dramatic to that. So it's really been a positive from a business aspect, but also from a patient care aspect. So yeah, it's been very positive.
Great. Excellent. And then Heather, for you, do you have any, I guess, color you'd like to add to the financial piece for ACL, in addition to what Dr. Scott just said?
I think it's been the same for us. We never went into this thinking about monetary gain. More, the discussion was, how do we make patients feel like they have a unique service with us? And the monetary gain is just the cherry on top. So we're grateful for it.
Great. Excellent. Last question for you then, before we pause. Many specialists, and I haven't seen all these questions yet, but perhaps there's one of these in here. Many specialists think CCM is for primary care. It's for the Dr. Scotts of the world, right? Not us. So if someone was to ask you that, like I am right now, how would you respond?
Sure. Our docs had that conversation when they made the decision to pull the trigger. Essentially, their philosophy was, well, I don't want to step on an internist's toes. However, we run the ball. So if we're able to understand the full story and understand the patient, and just like their blood pressure, maybe we have them on the wrong medication, it's elevating their blood pressure, or maybe we're giving them too much prednisone and it's impacting their sugar. Those are things that we need to know so we can make adjustments so they can have better experiences with their internal medicine provider.
Got it. And have you run into any issues where you are stepping on the toes, or has it been
they're grateful that we're catching it. So
the PCPs, yeah. Mm-hmm. Yeah. We always stress it's. I think the latest data shows about 5% of providers are doing this. So there's a huge demand. Mm-hmm. This is why we think, again, Dr. Scott, for you, 63% enrollment. Patients need this. They want it. PCPs in the area. Maybe doing it. A lot of specialists now are migrating to this because, again, they are treating these patients for specific conditions. So with that, I'll pause. We have a bunch of questions here. I'm going to start with one here. I've anonymous, and I'll see which of you wants to take this. The question is, we're having struggles engaging more patients within the CCM program. Any advice on how to increase our patient number and retention? So I would discern from that, one, how do you increase your enrollment numbers? And how do you provide a service that patients want to stay in? Heather, Dr. Scott, either of you want to take a stab at this?
So I guess the easiest way to do that is address it while they're in the office, while they're experiencing a need, whether it's a blood sugar that needs to be addressed and followed up on by nursing staff, or blood pressure. That's the easiest way for me. We have sent out blanket requests for CCM. Those do have an impact as well, but it's very important that the patient understand the value that they're getting. And I think I can explain value very easily when they're sitting in front of me. It's a little more difficult, through other methods, but it still works. So, and a lot of times they will, in our region, there's a lot of weight putting in, if Dr. Scott thinks this is a good idea or is really helpful for you,
Yep.
then a lot of times that will encourage patient buy-in. So I think if the providers get behind it and put their name with it, so to speak, the buy-in tends to go up dramatically.
Excellent. Yeah, that's what we've heard. And what's unique, and that's probably, again, why your enrollment rate is so high. Heather, you've implemented a more modern approach to enrollment, which your providers haven't enrolled patients in the office yet. We haven't even tapped into that.
No.
Can you explain how you were able to achieve such high growth in less than a year?
Sure. We pulled our complete panel and sent essentially a blast to our patients, and we dripped that campaign a couple hundred patients a week, so Crystal wasn't overwhelmed.
Mm-hmm.
Patients would at first say ask questions to the effect of, is this spam, or I don't know, what does Dr. Brown say? And we would then initiate a phone call where we would educate them on the program and how it will help them and let them make the choice.
Uh-huh.
Then in the exam room, they would ask questions about it and the physicians would support it, because like Dr. Scott said, it comes from the top down, and the trust is built between the provider and the patient. So if they're endorsing the program, patients are like much happier.
Yep. Excellent. Having that endorsement, I think is again one of the reasons why your program has grown so fast, similar to Dr. Scott's. Let me see, maybe one more question here before we move on. I think a lot of these questions will be answered here shortly. How have your patients been able to handle text messaging? Many of our chronic elder patients are not tech savvy. I know this question will come up. It's on my list, but let's just get to it right now because this is a big one. I would like to hear both of you answer this if you're okay with that. But yeah, how have your chronic elderly patients who are not tech savvy or historically difficult to get a hold of, how have they responded to you guys primarily texting them?
I can start if it is easier.
Yep.
With our patients, our physicians really thought they weren't going to accept the texting because of their age. And in my head, I have a little aunt that I was thinking about that's 88 that'll text me to check on me. And I was like, well, my 88-year-old aunt can text, so maybe our patients can too. And we took a leap of faith and started attempting it. And now our patients love it. And they love it because especially the elderly population, they're at home alone a lot. And so they feel like there's someone listening to them, and they don't want to burden their families a lot of times because they're already relying on them for transportation or other sort of caregiving task. And so Crystal's really a friend to them, and they love texting her about their lunch or about their sugar dropping in the middle of the night or their gout attack. They'll text her about anything, but she's really been able to develop friendships with them that have helped them feel more inclined to text, I believe.
And real quick, because you mentioned something very interesting earlier, you said patients seem to be more open or honest via text as opposed to phone. And do you get that sense, and Crystal, get that sense that patients are more willing to open up and be more vulnerable or honest with what's going on because it's text and it's not live phone call?
Yes, 100% of the time.
Great. And Dr. Scott, to you, you came from a phone call based approach. And I think now it's about 75, 80% of your patients are what we would consider text enabled. They prefer the text, while you still have a minority of patients that still want those phone calls. Not that they can't mix, but yeah, do you mind adding some color as to how the response has been with your elderly population?
Same thing with Heather as far as my fear of the uptake or lack of uptake with texting, but that's not been our finding either. I actually asked the team this morning, how many patients out of the 900 or so that we have do you ask to be disenrolled because of texting, or they were getting too many texts? I think they said under 5. So,
Wow.
so the texting has not been an issue. You know, a lot of the things I'd forgot about was a lot of these older patients text their grandkids because that's the only way they're going to communicate with them. So their grandchildren have basically taught them how to text, and so they're more comfortable than maybe we realize. There are still a few, and we still make phone calls. That's not an issue, but the overwhelming majority are perfectly fine with texting.
Excellent. Yeah, that is true. Most of their grandkids are the ones teaching them now. So I think there's been a huge adoption of this just in the last 3 to 5 years. And not to say all patients will jump up and down to texting, but we're seeing, like you two, majority of them do prefer that. So we just got a question from Carrie, and I think it's a great segue into the next segment here. Let's talk about implementation. One of the first questions people think about when implementing CCM is whether to outsource it or implement it in-house. Dr. Scott, I'll start with you. 4 years ago, you made the decision to do this in-house. How did you make that decision?
Short and simple, I like control. So basically, I wanted to make sure that the same message that we were giving the patient in the office was also reverberated where they were on the phone at that time, and they were not getting mixed messages, whether it's what I told them a normal blood pressure would be for them rather than some protocol that was in a call center somewhere, and they would be getting mixed messages. So it's all about having control, making sure the patient had the same message every time they ask. So that's why, of course, we looked at outsourcing briefly, did the due diligence, but there was really never a decision as far as what would be the best for our practice.
Got it. And Heather, I would assume you'd maybe echo that same logic, but if you want to add any color as to when you made this decision a year ago, what was it about doing this in-house over outsourcing it to a third party? What was important to you?
We looked at outsourcing and actually almost had a contract signed before you reached out to us. And the decision was made once we realized we could use Crystal, one of our medical assistants, in a position where she could flourish. Mm-hmm. She's really good relationally, but she needed some flexibility, and she was able to achieve that through family. And because of that, she already knew all the nuances of our care team. So she knew if it were a Dr. Scott patient, how to respond to that protocol. Mm-hmm. Similarly, if it was for a nurse practitioner, she would know, oh, the nurse practitioner saw her last time and the patient is still not feeling well. Maybe we should get her worked in with a provider to get a different set of eyes on the situation. And I think that changed it for us because, like Dr. Scott said, we were able to get control, and it made it seamless for us to transition. So that's why we brought it in.
Excellent. Excellent. And I think the next question, which Carrie, this is getting to you. You have this decision to be made. You have your EMR right now. I don't know if you guys want to share your EMR, but you both have this EMR option. It has CCM capabilities. How do you choose another vendor? Well, let me start here. Why not just use your EMR? And Dr. Scott, I know you did use your EMR for 3 years. If you just want to kind of discuss kind of the successes or pitfalls that you had with using the EMR for CCM.
Yeah, so we have a Prima as our electronic medical record, and so it's full service billing, everything, appointments through that. It just did not allow us to have the impact and outreach that family could offer us. We were only doing 130 a month billing. And two, is very clunky in this particular aspect. It was maybe an add-on feature, not a design. Mm-hmm. So that's why we found that it was not the most efficient process for us. And so family does not integrate with a Prima. It's two totally separate systems, which sometimes is a scare for people, but it's not been that way with us at all. It's worked seamlessly. A double screen makes things very easy. Yep. So we just enter things into a Prima that need to be there, that make an impact in the patient's care. And everything else we leave in family.
Yeah, and I want to get to integration here in a minute, because that is a big question that'll inevitably come up for some of the attendees. Back to the EMR. So just to summarize, it sounded like the EMR was, you mentioned clunky. Again, phone call based approach, correct? And I think a thing we always stress is scalability. How do you take one care manager and manage more patients and touch these patients more frequently? What about the kind of the other components to CCM in terms of workflows, enrollment, billing workflows, documentation, time tracking, all of that? What was that experience like with the EMR and a Prima support, for instance, for CCM?
So they do, Prima does have some time tracking capabilities. All of the consenting was signing a paper document, scanning it into the system. And again, this is all phone calls. So it was, when we reached out by phone, one of our nurses, we would click a button and start recording the time and things like that. So it's a very manual process. There was not a lot of automation. So I think that's kind of really what sets a family apart, and how it's added to our program is so there's some automation to the process.
Great. And Heather, any comments from you when you made that decision not to go outsourcing, but you wanted to use Crystal and you wanted to do it in-house? When considering your EMR or a company like Family, what were some important factors that you included in that decision?
We use NextGen, and I'm sure there is an adequate product. However, I needed to know, as we were scaling this business service line, that I had really strong support. And with our EMR, a CCM program is just a blip on their radar. But to you guys, it is the radar. So if I stress out over not understanding how to put a diagnosis in a care plan, or this medication isn't popping up, I can email or even text in many cases you guys, and somebody is on the horn immediately correcting the problem. And so that partnership seemed really important for us, because there's so much fear with launching a new service line.
Yep.
That Family was, really able to kind of calm those waters. Even when we got in kind of deep or took on too many patients too fast, you guys had the tools to kind of surround us and get us back on the ground that we wouldn't have had with NextGen. They're great, and they have a product, I'm sure, that would work adequately, but it didn't provide us the comfort that we needed.
Great. Excellent. Appreciate those kind words from both of you. So then back to Dr. Scott, to your point just now about integration. Heather, I was going to maybe bring that question over to you. So how have your providers responded to Crystal and your staff using a second software to help with CCM? Has their day-to-day changed much? And what information is Crystal and your care manager sending into NextGen for the providers?
If it is a medically important event, patients had surgery, their medication has changed, they stopped their medication, they had an allergic reaction, that information is then typed into our phone template, which is a traditional method for receiving information in our clinic. She'll type that and then send it to the provider. If it's an FYI or if action is necessary. But like Dr. Scott said, everything stays outside, and they like it because there's not a lot of clicks that they have to go through to find what they're looking for. They know everything family related is on the family dashboard, and everything EMR related is in the EMR, and it works great.
Got it. Excellent. And Dr. Scott, again, from the provider, how is it that you're receiving information from your care team?
So same way. So they send a message through the phone message bank and ask for input or let us know that something has transpired that we need to know about. Same method.
Okay. All right. I think what would be helpful for the group here is kind of zooming out and just talking about general workflow. So how has that workflow fit into the way you're practicing medicine? Was it disruptive? Was it something where you had to rework all these different workflows to incorporate CCM in, or does it kind of fit nicely into the way you're already kind of operating at the clinic?
So the way we set up our program was if a patient is CCM, then those CCM care managers take care of everything that patient needs. So if I see them in the clinic and I refer them to cardiology, then I send that referral to the CCM team, who then makes the referral. If the person's not in the CCM program, it's a pediatric patient or an adult, it goes to the referral specialist. So everything that patient needs who's CCM goes to the CCM care team. So if they happen to call into the clinic, they get the CCM team. If they need a refill, it goes. So anything at all related to what that patient needs is handled by that team. So they really understand all the nuances with those particular patients. There's just a few hands that are caring for them, so they don't have to repeat the story over and over. So again, it's like concierge for them, and so they really enjoy that. So as far as workflow, it's allowed my nurse that helps me when I'm seeing patients in the clinic, so that she doesn't have to stop what she's doing or call what that patient needed or the specific and nuances for that patient. The CCM team can manage it. So it's whether it's filling out handicap car tags, disability paperwork, CCM team, if they're with that program, then they are able to handle all that. So it's really segmented out a population that gets that hands-on one-on-one care.
Yeah, 65% of the Medicare, as we were saying earlier, right?
Mm-hmm.
I think if we dig a little bit deeper, can you just talk about your CCM team? What is that structure? What are these roles and titles and responsibilities? How'd you think about building that CCM team for these 900 patients that you care for?
So we've had some transition in our team. So right now, Mary Ray's been doing it for several months. She has, I think, 6 or 7 years of nursing experience. She's an RN. And so she heads up the team. Then we have a medical assistant who fields messages, does a lot of the phone calls. And then there is a halftime FTE that splits her time. That's taking messages off the phones when someone calls into the front desk. So this team also helps take care of our annual wellness exams. So that's all in their wheelhouse. So we have 2.5, probably pushing towards 3 FTE that are helping us manage this patient population. So it's not family as one component of it for us, but basically, like I mentioned, if they're on the CCM panel, then that team is responsible for helping coordinate all the care that they get.
Excellent. And their day-to-day, you just kind of walk through it, so I won't dig into it, but it sounds like about 2.5 FTEs for 900 patients or so, and that's CCM as well as AWVs and wellness visits, like you said. Heather, what is the structure of your CCM team? Is it similar to Dr. Scott's? What are their roles, responsibilities? How did you build that out as you grew so quickly in the last 12 months?
Our structure is slightly different. We use a medical assistant, and she's all we have. And I help her when she feels like she's getting overwhelmed, and it's working for now. However, as we grow, we'll have to add another support team member full-time to the program, and it'll be valuable. What I had told Crystal early on when we transitioned her into this position, I just very frankly said, if you want a job here with the flexibility that you need for your family, this is the number you have to achieve every month.
Mm-hmm.
And she doubled it.
Great. So you have one MA, I believe. Have you found yourself pulling in other members from the clinic to support Crystal? And how hard has that been to onboard someone like that for CCM? Is it a long, strenuous process, 10-week training, or has it been very quick? Yeah.
No, the program is pretty intuitive as far as pulling in information from the EMR. Most of the check-ins we have are automatic templates, so it's not as if I'm sending when she's on vacation, for example, it's not that I'm sending 900 different messages.
Yep.
And so that helps a lot. And occasionally we'll pull in my executive assistant if we have an influx of care plans that need completed, and he'll help us with a chart review. But beyond that, we're able to really
manage it,
rely on Crystal.
Mm-hmm. You just need to clone her a few times and
I know.
ship her out to everyone on this. So that's great. I think we're getting some questions here. I wanted to pause, but we got a question here from Amy Andrews, and I think this is the segue. I think this is a key part to this as we wrap this up, which is just going to overall successes and pitfalls. I think a lot of people on this right now are just beginning this journey into CCM. Maybe they've been trying it, they've been piloting it, maybe they're just now being introduced to it. I think what's of immense value to all those out there that are just starting to look into it is understanding from both of you two things. What pitfalls do you think others need to avoid when doing their own in-house CCM program, and what advice do you have both for those looking to start their own programs or optimize their current one? I would encourage to hear from both of you if you don't mind.
I think for us, it was important to scale it. So we started, I don't remember, Austin, you might know, but I think we started with maybe 100 patients, and then we went to 200, and then we went to 300, and then we said, okay, we'll go to 5. And so we really tried to perfect each level to where patients didn't feel like it was a robocall or it was impersonal. And
Mm-hmm.
because of that, I think we were able to retain our patients, and we were able to do it in a way that felt authentic and true to the business plan.
Got it. So your suggestion there is, as you scale is important, you think, for those starting out.
Mm-hmm.
For it to be impactful, to drive the results that you're seeing, getting scale is important. But when you scale, making sure not to sacrifice that the personal touch, right, and the clinical impact per patient, I believe is a way to summarize what you just said.
Yes.
Great. And Dr. Scott, for you, I think question, since you've been doing this for 4 years, I guess, one, what are some common pitfalls that organizations need to be aware of as they look to start CCM?
So I think mainly implementation, to make sure that you understand all the rules and regulations and guidelines that are required. Making sure that when you sign someone up initially, that there is some recall feature. So when you know when that consent expires, that they're due to reinitiate that consent for CCM. And then make sure that you find a team member that wants to own it, that is motivated, that doesn't require micromanaging, that can take a goal and really make it their own and run with it. Someone that can make decisions within a framework very easily without having to be asked a lot of questions. So I think finding the proper team member who can work independently within guidelines, and then making sure that you understand the rules of the program, and then the re-sign up process, making sure that doesn't get lost in in the fray as you begin to scale the program. So those are the things I would watch out for.
Excellent. No, I love that comment on finding the right person, finding that care manager that's going to be a good fit. That's impactful for the patients, which obviously just gets more buy-in from the patients. One question, and I feel it's been asked quite a bit of times, and I knew we'd get to it, is copay. So we hear from a lot of people, some patients will have copay, others won't. But how has the copay concern or question from patients been for you? Dr. Scott, I'll start with you. Have you had this conversation a lot? If you had, how do you walk through the rationale to a patient as to why that copay is worth it? And I mean, have you seen a lot of patients unenroll because of copay?
So I delegate that conversation. But this is when I asked my team about this, asked them the same question this morning. So out of 900 patients, so obviously more people are getting copay requests or bills for the copays than they did before we started family. And they said they probably had less than 10 disenroll since we started family back in October because they got a bill for the remaining balance. So what my team has done, and we've kind of worked through this process, is they will look to see if the patient has a secondary insurance.
Yep.
And so then they're able to tell them, most likely that secondary insurance will pick that up and there'll be no additional copay. If they see they have no secondary insurance, then they tell them that this is going to be $6, $8 or whatever it ends up. If we end up, reaching that 20-minute threshold. So it's not going to be a monthly recurring charge unless there's a service provided that meets that threshold. So, and that's part of the consent process. So as long as they understand that, know that up front, like I said, they said less than 10 people disenroll because of that copay that they got.
Great. Yeah. And I think one of the questions is, so it looks like you kind of segmented, your Medicare plus supplemental, and there's good reason to believe those patients won't have a copay associated with this because the secondary or supplemental will pick it up. It sounds like you guys explain that to the patients during the enrollment process. And then there's that population of the Medicare traditional, which will have that 80-20 split. And then there's a conversation about, hey, this is worth $6 to $8. If anything, try it out, see if it's worth it. And like your team has told you, less than 10 out of 900 have unenrolled in the last 6 to 7 months. So they're obviously finding value from that, and it is worth that $6 to $8. I think another question, and I can maybe just answer this, is, what percentage of Medicare patients have to pay out of pocket? I think that question there is what percentage of your patients have supplemental, which ones are traditional? I think the national average is about 67% of Medicare patients do have that supplemental. I guess, is that in line with your experience as well, Dr. Scott?
Yes, that's about right.
Great. Okay. Heather, I want to ask you the same question too. Have your providers complained about the copay frequently? I guess is a safe question there. How much has copay come up for your patients?
Initially, when we started the program, we made a decision to just very forwardly tell the patients the cost and charge of the service. And so when we set that expectation for our patients who understood what a statement would look like or what the bill would look like if they received an EOB from their insurance plan, there was no problem. Some patients with lower health literacy who didn't understand the value of the program did decide to opt out. And it's okay, because that means the program wasn't for them. We didn't want to force anyone into a program that they didn't find value in. So we just said, okay, this charge will not continue. It's on a monthly fee. It was only for this service at that time. You don't have to use it anymore. And the conversation was not hostile. It was very polite.
Yep.
And we just went on to the next patient. Some patients don't want any charge or any additional fee, and that's okay.
Okay. Excellent. I want to pause there. I mean, we're already over. It's 5 minutes. We still have majority of the attendees still here. I want to respect your time, Heather and Dr. Scott. We could spend maybe another 10 minutes to go through some of these questions if you're okay with that, or we can end it here. Would you guys be okay if we ask some of these from the group?
Sure.
Okay, excellent. Let's see. Heather, for you, are there specific patient populations or conditions you target for the program? And how do you determine, I guess, how do you determine what chronic conditions and patient populations this is valuable for?
We look at our top conditions that are presented. So we're looking at rheumatoid arthritis, we're looking at lupus, because generally those people will have additional conditions when they're presenting to us. They want answer because their whole system has been impacted by this disease. So we target those individuals. However, we have found that many of our patients have landed into a rheumatology clinic because they have multiple conditions. So they may have, I saw in the comments, there was a question about joint pain. They may have joint pain, but also diabetes, but also ulcerative colitis, as an example. Okay, that's multiple conditions. We don't necessarily treat every single condition, but it does play a part in the entire treatment plan. So that's how we have, that's the, I guess, the mindset that we've adopted to maintain these patients.
Got it. Excellent. Yeah, that's really helpful coming from the mindset of the specialist, right? To understand, because one of the questions in here is, as a specialist, are you billing PCM? And you're billing CCM, right? Which is 2 or more chronic conditions.
Right.
So there's a distinction to be made there, that the patient's eligible for CCM, yet you are not responsible for, like you said, managing the ulcerative colitis in that example. Let's see. Dr. Scott, I want to ask you, for Dr. Scott, what standing protocols do you have in place and would be willing to share electronically to duplicate in other sites? I guess maybe at a high level, can you just walk through what is your protocol to enrolling a patient in the office? Maybe that would help answer this question.
So basically, if in our EMR, we have them flagged for the patients who are CCM active. And so if I see that the patient is Medicare and there's not a flag for CCM active, then I will begin discussing that with them. And then I'll ask one of the CCM care team folks to come in as I finish the visit to get the consent, give them some information about it, how they can be contacted. And so it's all, that's how we do it one-on-one in the office.
Okay. And then your protocol after that is your day-to-day doesn't really change. You receive information from your CCM team. They understand what needs to be escalated and what they can handle. Right. And you're going on your day-to-day. Yeah, I don't know for who submitted that. Hopefully that's sufficient. I think this is going to be the last question as we wrap up here. And I want to make sure I'm asking this correctly. What type of guidelines do you use to determine what is billable as CCM? So again, we have this long laundry list, prior authorizations, phone calls, messages. You guys are doing texts, you're doing medication refills. Dr. Scott, maybe you're calling out to a pharmacist. Again, what is the framework as you determine what is activity that's billable as CCM?
So basically, any care that I give to that patient while they're not in the office, we count that as CCM time. So if I'm refilling a medication, if I'm talking with a relative who's on their HIPAA list about what we talked about in clinic that day, if I'm reviewing records for a visit, so anything that's related to the care of that patient, you can count as CCM time. Okay,
excellent. I lied. One last question. I'll put you both on the spot. In one sentence, I guess, as individuals and organizations look at getting involved in CCM, what's your one sentence, I guess, advice for everyone out there as they think about pursuing this initiative? Dr. Scott, I'll start with you.
I think once you've done your due diligence, you'll find that it is a good decision for your patients, but it's also a good decision for the business.
Right. And Heather, last but not least.
I agree with what Dr. Scott said, and our focus just continues to maintain that we want to give patients true care. And a way to do that is to offer them additional services.
Great. All right. Well, we are coming up to an hour to conclude this webinar. Want to thank both of you, Heather and Dr. Scott, for your time today. I hope this is has been impactful and informative to all who have joined. I apologize. I know there's a lot of questions that came in and we weren't able to get to all of these. But as I said in the beginning, we will offer up a follow-up email here. If you guys want to learn more about family and what we can do, if you have questions that are unanswered, please reach out and we'll be able to help answer some of these because I know there's a lot still out there. There will be a recording sent here shortly. There will also be a survey that we will send. We appreciate any feedback on what you thought of this and what you took away from the webinar. So with that, I will let everyone go. Dr. Scott, Heather, thank you again. And for all who joined, thanks for spending the time.
Thank you.
Thanks for having us.
Yep. See ya.